It's very humbling to present the next speaker. Is a guru in obstetrics and gynecology, Professor Vwalika. He works for the University of Zambia. He's an epidemiologist, and he's also Secretary General for ECSACOG and also one of the founding members. He says as an adjunct professor at the University of North Carolina Department of Obstetrics and Gynecology in the USA. He has been external examiner in many countries, including Zimbabwe. He came at least twice to our department, and I think some of the students here, our gynecologists, were either passed or failed by him. So he has over 150 publications, and has written 2 book chapters, and the review is the review of many local and international journals. I think we'll go on and on and on and on, but Professor Vwalika is going to speak on the role of ECSACOG in SRHR in East, Central, and Southern Africa. Please, most welcome, Professor.
Good morning, everyone. And welcome to my talk about the role of ECSACOG in SRHR in East, Central, and Southern Africa, which we belong to. How do you move this clicker? So, SRH really comprises improving the maternal and newborn care, providing quality services for family planning, eliminating unsafe abortion, and combating sexually transmitted infections, and finally promoting sexual health. Promoting of SRH is one of the key objectives if we are to achieve the SDGs that we are currently embarking on. And the current indicators show that Africa still lags behind the rest of the world, and more effort is needed to achieve these SDGs. Of concern really is that the causes of maternal mortality remain the same. Over the years, we hear the same things such as PPH, hypertension, abortion, but very little progress has been made to address these causes. We seem to be going around circles. So we would ask, why do women die? Why do they die? Women die as a result of complications during and following pregnancy and childbirth. We've heard about this in this meeting that we're having. But what is ironic is that most of these complications that develop during pregnancy are preventable or treatable. We have also other complications that may exist before pregnancy, but are worsened during the pregnancy, especially if they are not well managed. As already mentioned, the complications or killers of these women are still the same. We have PPH, infections, a high blood pressure, and other complications from deliveries. We've heard about obstructed labor. And one constant is unsafe abortion, which is indeed preventable and treatable. Not mentioning the remainder of the other associated causes which are worsened during pregnancy, such as malaria, HIV, which are common in our environment. Now, people have estimated that every day, 850 women are dying. And these women could be somebody's wife, aunt, sister, or daughter. And 99% of these maternal deaths occur in the developing world, which is ourselves. Maternal mortalities are worse in the rural areas, amongst the poor. In our environment, some of the countries reach as high as 1,000 maternal mortality ratios, which is really unacceptable. And the young people seem to face the higher risk of complications and death than other women. We've heard in this meeting that we lack skilled manpower. Skilled birth attendant is lacking. And all these can be called preventable deaths if we improved the skilled birth attendant in our environment. If we look at statistics between 1990 and 2015, the maternal mortality worldwide only dropped by 44%, which is again unacceptable. And if we continue at the current rate of managing our women, we may not achieve the SDG goal of 70. We know some of the preventable contributors, again, which are not magical to achieve. We have very low contraceptive prevalence rates in our environment. There is high unmet need for contraception. We have very high total fertility rates in our environments. So we see that we are having a lot of children per family. Big families are a driver for poverty, so the resources are not growing, and yet we have a lot of children being born. And some of these pregnancies are unplanned. Instead of having pregnancies by choice, most of them are really unplanned for. Now, having recognized that sexual reproductive health and rights are an issue in our environment, there have been different responses. And one such response has been from World Health Organization, the Africa region, and this has been called the SRHR initiative. So this strategy is meant to support country strategies to reduce maternal mortality in order to achieve the SDG targets through health systems approach. So this strategy began in 2019, and it places emphasis on eliminating maternal deaths due to unsafe abortion. And this strategy has been implemented in 5 countries, which include Rwanda, South Africa, Benin, Côte d'Ivoire. And the countries that participated were selected based on the high maternal mortality, high rate of unsafe abortion, and these countries demonstrated clear political will and commitment to end preventable maternal deaths. And WHO has created a scorecard to monitor progress. I'm sure if you talk to representatives from Rwanda, they will tell you about the successes that they've scored in this regard of reducing unnecessary deaths from unsafe abortion, increasing access to safe abortion. South Africa also have got their own good stories about the progress that has been made so far. So we applaud WHO for recognizing and responding to the rights of women with regard to their achieving their health. Now, back to where we are here, we have ECSACOG, whose presence, for some of you who don't know about ECSACOG, is being shown by the collaborative efforts that it has come to be with ZSOG. And ECSACOG is a collegiate training institution with a mandate to train specialist obstetricians and gynecologists in our ICSA region. So this ECSACOG was officially launched 5 years ago now, in 2017, in Rwanda, Kigali, following a resolution passed by regional ministers of health. And the justification for the collegiate training is that if you look at in our region, the problems are the same. And we started training specialists by sending them to England, USA at great cost to our countries. But most of these specialists never came back. I applaud the 2 professors from Zimbabwe who managed to come back, but most people have not come back. So this was a loss to our country. Then the initiative was to develop the MED program. The MED program is a university program and on average takes 4 years. So these universities were mainly found in the capital cities, in Harare, in Lusaka, in Nairobi, in Kampala. So it meant that people left their districts or provinces to come to do training in the capital cities. So you find that 4 years is a long time. After graduating with your MED, you're a specialist, people found themselves settling in the capital cities and they never went back to their rural districts where they came from. And now they are marketable, they can do their private practice in the capital cities where money is found. So this is a justification of creation of the collegiate training, which does not require people to leave their provinces to go to the capital cities for training. So they could use the provincial accredited hospitals for training, and it is hoped that they will not stay away from where they came from, and their training is part of the regional planning of the health authorities. So as indicated, our main mandate is to start training, and we were motivated by the success of the surgeons, the COSEXA. For them, they've clocked more than 20 years to have started the training, and this has had high impact. So having put up systems, the East Central and Southern Africa College of Obstetrics and Gynecology finally started the training this year on the 1st of September. And as ZSOG is hosting us, I want to commend you that you have actually got the highest number of trainees enrolled in this program, 19 of them, which is a very high enrollment. Rwanda has also started the training. Kenya equally has started the training. So you see that by the end of the 4-year training program, you have a lot of specialists being developed of high quality that you could practice anywhere else in the world with confidence. Now, if you've read the constitution of ECSACOG, you see that our vision is really falling into place. We are supposed to be an authority. We are supposed to be a reference body for reproductive, maternal, and newborn care in the region of East, Central, and Southern Africa and beyond. So whatever we are talking about in relation to reproductive health, maternal, and newborn, we are the authority. So we should be calling shots. We should be directing what should be done properly. Now, along the way, as we've been developing the college, we've tried to create partnerships with various organizations. You see that WHO has played a big role in this meeting. We are collaborating with them. We have the Royal College of Physicians of Ireland. They are collaborating with us. And the mother body of obstetrics and gynecology, FIGO, is collaborating with our college in addressing SRHR issues. So in this collaboration with support of FIGO, we as ECSACOG developed a sexual and reproductive health committee. This was established comprising eminent members of the college based on their substantial experience and passion in this area. The committee brought expertise and drive to ECSACOG to work in the field of SRH, especially focusing on leading the advocacy efforts, knowledge sharing, and capacity building. So formed partly in response to this ECSACOG's new engagement with FIGO, the partnership started specifically in April 2022 and it will end in March 2023 as part of their advocacy safe abortion project. My colleague will talk about some of the activities that is being implemented in this regard in 10 countries in Africa. Now, acting as a steering committee was one of the recommendations of this committee that I talked about, and it will run until 2023 along this partnership with FIGO. And this led to the development of a community of practice for obstetrics and gynecology with interest in sexual reproductive health, including safe abortion. So this committee, this is written in future tense, but it has finally been formed, comprising a group of professionals that are passionate, who are advocates in the region, and it will form as a group for sharing knowledge. And this community of practice comprised representatives from 10 of our countries that are currently in ECSACOG. So each country contributed 2 specialists who are passionate, making it 20 altogether. And the plan was to have at least 2 meetings to brainstorm what work can be done with regard to SRH in our region, particularly the work focusing on preventable causes of death, the abortion. The first meeting took place in Kigali, Rwanda, last week, 5th to 8th of October, and some recommendations have been made, and this will be submitted for ratification to the AGM this week, tomorrow. So, as I've preempted already, the community of practice has been formed, and some of the resolutions of the meeting that took place last week is that we need to work towards the prevention of unsafe abortion in the ICSA region. And also we should ensure that we include the sexual reproductive health and Rights, and CAC in pre-service and service training in our region. We also hope that as a way of achieving these resolutions, we'll make ECSACOG develop a position on abortion to guide member states, and also address stigma and raise awareness by conducting values clarification exercises. We hope to have one such exercise on Saturday, and also inclusion of the topic in all national conferences and AGMs by community of practice members. We also wish to use any further opportunities in the future. In other words, we need to engage in regional advocacy, which will be decided as we go along. Now, as the plans with FIGO are ending in 2023, we don't plan to stop the community of practice. We hope that this will continue. There will be continuation also of the SRHR, and there is need for further integration of SRHR in the ECSACOG curriculum. It is currently existing, but not amplified as we would want it to be. FIGO has offered to continue supporting us develop and the capacity, and also explore further opportunities to make us grow. Thank you very much.